Welcome to the UNC Core Center for Clinical Research Speaker Series. We appreciate you taking time to join us for this presentation. We have two presenters today from the Netherlands. I'm going to introduce both and then they will give their talks in sequence and we'll have questions and answers at the end. So first we have Simon Masbergen, who's an associate professor in Rheumatology and Clinical Immunology at the University Medical Center Utrecht. And he has an interest in translational rheumatology research, which will be very relevant to our group, with a focus on tissue regeneration and joint disease, especially in OA. And he's also interested in modulation of cartilage, synovium, and bone to prevent and eventually, hopefully, cure joint damage. After Simon, we'll have Mylene Jansen, who is a postdoctoral researcher in the same department at Utrecht. And she's going to give us an overview of the approach study and some of her work, which has been pretty substantial in recent months, to give us kind of an update of where that study is. So I will turn it over first to Dr. Masbergen.
Okay, thank you very much for the kind introduction. Indeed, I will start with a short overview. So we'll be the coming 15-20 minutes, a short overview of what we do in our department and specifically in our research line. And from that on, Mylene will take over and present more on the approach, as Dr. Nelson already mentioned. So let's see if we can skip to the next. Yeah. Just to be clear where we are from, indeed, we are from the Netherlands, but not only we are from the Netherlands, we were actually from the center of the Netherlands because we are in Utrecht, as pinpointed here. Here you can see an aerial picture of our hospital on the scientific campus of Utrecht. It's a quite large hospital where about 12,000 people are working, and it's one of the larger hospitals in the Netherlands, not the largest, but one of. And we actually have 3 locations where we perform our research. And we have a laboratory at the Regenerative Medicine Center of Utrecht, which is located in the Hubrecht building in the campus. We have another place on the Central Translational Immunology laboratory, where we also perform work from our department, but we are not ourselves present. And our main work is focusing in the center of the hospital, where you can here see a picture of a typical workplace, I think also familiar for you guys there. And in addition, we also have the ability to do radioactive work in a separate lab. So that's why the sign is also there. So we have a lot of facilities and a lot of opportunities where we can do our research in this hospital. Our overall question that we are interested in is mentioned here, summarized here: the mechanisms of tissue structure, degeneration and regeneration. Specifically, the latter one is, I think, the most interesting one in rheumatic diseases, and with a specific focus on osteoarthritis. Myself, I'm already working more than 20 years in this field, so I'm still focusing on OA, which tells something about the progression that we made, at least in our place or in the field as a whole. But there's still a lot to learn and still a lot to understand. Here you can see an overview of how our research group is structured. We have our head of the department, Dr. Heistek, and manager of research is Professor Lafeber. Probably you also know him from the OA field. And underneath that, we have different PIs, all responsible for different research lines within our group. So we do research on systemic sclerosis, we do research on rheumatoid arthritis, we do specific research on Sjögren disease, and we do research on immune deficiencies. But today we will focus, of course, on the osteoarthritic research line, which is headed by myself, together with Professor Lafeber. We also have a clinical study team which can support us for the clinical studies that we do in our department. They support us for all those research lines, and the clinical study team is led by Dr. Marijnissen and by the rheumatologist Dr. Julia Spierings. And of course, in all those research lines, we have support from the technicians, research nurses, and we have the PhD students who are doing a lot of the research, the actual research, I would say. So that's for the whole department. Here you can see a little bit more focused on my group. Like I mentioned, together with Flores, I'm responsible for the research in the osteoarthritis research line. We also have Paco Welsom, who is also PI on itself, but he's a statistician, so he supports us as well, which is very handy to have a statistician almost literally, typically sitting right beside you. Then we have Mylene, who is postdoc within my group, but she will introduce her work, of course, more herself later on. Then we have several PhD students working. At the moment, we have, well, there are 6 here mentioned, but recently 2 of them did their defense, so they left us. So now we have 4 working at the moment, but new ones will come soon. And then these are the 3 technicians who support specifically in the OA research line. So it's quite a bunch of people that is working on the OA within our department. And again, Anneke Riemer-Reinissen, but also the research nurse Karen Schrijvers is specifically supporting us for the OA studies that we do. Within the OA research line, we have sub-questions that we study, and each photo that you see here is an image of a thesis. So as you can imagine, in the different research lines, we already do for a prolonged period of time research. So we really try to focus and try to hold on our research lines. It can be roughly be divided in 3 lines, which is the upper line is intrinsic cartilage repair in OA, which is specifically focusing on the role of joint distraction. And later, we also focus it more on the role of stem cells in the regenerations that we see with this treatment. We are interested in phenotyping and demode development or therapy, or studying effects of potential demodes. Regarding phenotyping, of course, the approach cohort is a nice example, which you will hear more about in a moment. And a 3rd line, which we are working quite some time on, is the blood-induced degenerative joint damage, which is specifically mostly visible in hemophilic patients. Within our hospital, we have a specific hemophilia department, which has the largest group of hemophilic patients in our country. And as you might know, hemophilia is a clotting disorder, only occurring with male patients. And already from a very young age, they have spontaneous bleeds in their joints, and those joint bleeds affect the joints quite severely. And on a very young age, those joints are already destructed. And when you look in more detail to the disease, it's a kind between rheumatoid arthritis and osteoarthritis. So it's a very nice niche to study and understand also the principles for the OA and the role of blood. So also in case of trauma, this can be of interest. All these theses are in the past. Each thesis is about 4 years work on average. So quite some time that we spent researching in these 3 lines. But at the moment, this is the division of the PhD students working on each line. As you can see, there's the most focus on the intrinsic cartilage repair studies, and also the blood-induced degenerative joint damage. Like I mentioned, the last period, we have a couple of successful defenses of their thesis. So Astrid did it in September last year, 2021, and Eefje and Michelle did it in March, so quite recently, and left our department as well. Goran is currently working on the combination of joint distraction and a hydrogel, specifically for OA, and he's studying that in a large animal model. We use the DOC, which is a model that we developed in our department, in which I was also involved. And here you can see a rough outline, which is his main experiment. And then you think, whoa, is that only one experiment? This is an experiment which will take approximately 2.5 years to complete, because we do a quite large amount of animals, which we cannot do all at once. So this is a big study, which is quite exciting and sometimes frightening whether we can make it till the end. But yeah, and this is for the first time that we combine joint distraction treatment with another treatment, although this is in an animal model. So also the outcome of this can be relevant for the human situation. Just to give you an idea about the type of work that we do and what we can do with those animals. And we're looking at the analgesic effects of the combination. So we measure pain measurements by force plate analysis. We look at the anti-inflammatory effect by synovial fluid analysis and tissue, but also biomarkers. And of course, we are interested in the chondroprotective effect of the combination of this treatment, where we can study cartilage and again, biomarkers. Quite a big study and different parties involved, of course, and we're working also together with the Technical University of Twente, which is another technical, one of the 3 technical universities in our country. This is Eline van Bergen. She's working on the blood-induced joint damage, and she's focusing a lot on the role of biomarkers in this disease and whether we can use biomarkers to detect an early bleed in the joint or and what the effects are, and also in combination again with joint destruction. So here we translated the joint destruction treatment from the OA to the hemophilic damage. And recently she visited also Nordic Biosciences, one of the initiators also for us to talk for you today. And the next, well, within a couple of months also, one of the PhD students of Nordic Biosciences will visit us for another part, for another project. So here you can see a really fruitful collaboration starting off with this type of work. We also collaborate with other groups in our hospital, specifically with Niels Eikelkamp, who is a pain specialist. Last 5 years, we are very interested in the biological role of pain in OA. So much more, where is the pain coming from, and can we separate it from more the physiological or psychological pain, and look really at the damage and pain involved. So that's really a nice add-on to our own expertise to have and to incorporate. And for instance, we're working on understanding the role, how pain can be diminished by, for instance, a combination of IL-4 and IL-10. A spin-off of that is actually that we did from the approach cohort, where we looked at a specific questionnaire, and there we identified that certain patients had a more neuropathic type of pain than, let's say, a more osteoarthritic type of pain. So that might be a specific group of patients. This is, of course, very early and preliminary research, although it's been recently published. But yeah, I think it's a nice way, again, of showing the spin-off of collaboration, as you, of course, are aware of. I mean, that's not different at your university. But I think it's very good to have that multidisciplinary and different disciplines around to really understand what's going on with the patients. Not only clinicians and scientists, but also different type of scientists. One of the advances of our campus is that also the veterinary department is located at our campus. And therefore, we collaborate also with the veterinary department, specifically on our animal models. Although we do specifically experimental models, but we can also translate our findings to patients, animal patients. And Michelle, who has recently obtained her PhD, she focused on understanding on which time point the effects of joint distraction occur. And we always thought that during joint distraction already the repair started, but we learned from her project that during joint distraction there's more a kind of degeneration taking place, and later on, after the treatment or after the frame is removed, there's actual regeneration occurring. So we think that afterwards, the period after the treatment is at least as important as during the treatment. And that is something new that we've learned. And for the first time, we also treated a patient dog who had severe OA with joint distraction, although that also was an experimental treatment. But nonetheless, it was very successful. And already for 2 years, the animal is functioning way better and almost pain-free, instead of, which is possible in the Netherlands, getting a knee replacement. Also in dogs, we can get a knee replacement, like the humans. So also here we seem to be capable of delaying joint replacement for severe OA also in animals. You can argue whether that's a thing you really want to do for companion animals, but in the Netherlands we think it's an option. And in all those, well, in most of our research, we always want to have a translational approach, and meaning that we want to have all the aspects included in the work that we do. So when we have a question coming forward from the clinic, we want to study that in vitro. And if there's a reason to study it in animal models, we want to include it as well. And we have the access to smaller animal models, but we have the preference for the larger animals, which is quite unique nowadays, at least in Europe, to use the larger animals like the dogs or a sheep or a goat. And in our laboratory, we have access to human material as well. So we do tissue cultures at most. So we obtain, for instance, from joint replacement, we can obtain OA cartilage, but also from abduction from people without joint problems who died from other causes, we can obtain healthy cartilage where we can still do some studies. And of course, we do clinical research as well. And a couple of examples for clinical research is, of course, the Approach cohort, but also we do currently, we have the Zodiac Trial running, which is a trial where we selected patients specifically with bone marrow lesions, and we have a therapy with zoledronate, which is a bisphosphonate, as we believe that people with bone marrow lesions have a kind of bone phenotype, and we expect a better outcome when we treat them with zoledronate. And this is a placebo-controlled study, so we're really excited to see, well, somewhere next year, whether that's really of a value when you select those patients specifically with bone marrow lesions. And another clinical study that we have currently running is with the joint distraction with one of the frames that we developed in our department, and which is a study with 5-year follow-up, which is in 2025 finished. So that's still some time to go, which is a multi-center study in the Netherlands, and yeah, adds to the evidence that we collected so far to see whether joint distraction is a really sensible treatment for a specific type of patients. Not only we believe that we should be translational, but we also have a vision that we want to valorize our findings. So not only studying and doing the findings, but also try to really bring them to the patients via spin-off companies. And we have currently 2 of those companies. We have Synerkine Pharma, who is working on the combination of IL-4 and IL-10 as a fusion protein, which seems to be, at least in the laboratory, seems to be capable of DMOAD-like characteristics. And the other thing is that we developed, like I showed you, a specific joint distraction device, and we had that put in a spin-off, which is called ArthroSafe, which is trying to make the treatment commercially available. Besides making them commercially available, you also need to think about the implementation, because it's not only that when a company has a product or that you can start a company, you also need to implement it in the actual care. And that's also really a challenge. And that's also something that we learned from the joint distraction. We feel that we are ready to really implement it in daily care, but from our authorities, we were put on hold because they thought it was a promising treatment, but there was still not enough evidence. So we had to apply for another study, which was granted luckily, but now we need to do a very large study where we want to treat 600 patients with knee joint distractions versus 600 total knee replacements, which will be also a multi-center trial in the Netherlands, but put the therapy on a hold to be available for the patients for quite some long time, because this study will start, well, hopefully this summer, and will take us at least another 4 years before we have the results. So until we have the results, and the results shows the same as we have done before, then we should have a new judgment whether this is approved for daily care treatment. But that's the reality we live in, and that's how research goes, and what you need to do to get a treatment really to the patient, and why we are pushing for. Mylene did well. She defended her thesis and successfully last year in June, July, and luckily for us, she was willing to stay at us on as a postdoctoral researcher. And with that, we could expand our knowledge specifically on imaging. Mylene developed quite some algorithms and new methods to judge MRIs and gain knowledge to develop new ways to look at X-rays. So we are very happy to have us in our group and work still together, further together. And for instance, she also was successful to extend our collaboration, for instance, with Norwich University in the UK, where we collaborated with the group of James McKay and Tom Termsey, sorry. And we were able, with using their technique, to show, for instance, a 10-year follow-up and changes on cartilage, in this case, cartilage thickness, after 10-year follow-up of patients treated with knee joint distraction, which is recently published. So we're very happy with that. And even more recently, we also published the subchondral bone changes. So we're very happy that we were able to implement and keeping this knowledge within our department after the PhD period of Mylene. Another collaboration that she initiated was with the Image Biopsy Lab, which is a lab in Austria in Europe, and they have developed a program where they can where they make use of artificial intelligence to analyze X-rays taken in care. So they're not specifically standardized or depending on what, of course, what is your protocol that you're running at your hospital. But using their technique, we were able, which is called Koala, where you can measure automatically the Kelvin Lorentz grade and get a number for the joint space width, and compute imbalance between the two joints. And using their technique, we were able to confirm some of our results that we did in experimental setting with the joint distraction and X-rays, where we have standardized photographs. And with the non-standardized photograph, those were people treated in daily care for a study. And we were able to confirm our results with their program. So that was very nice to see that not only we were able to find similar results, and I won't go too much in detail what you see specifically here, but at least we could confirm our results with a different technique from a different type of X-ray. And that's at least is reassuring that we're doing something useful. What we feel is that with joint distraction, that we have a system where we can at least show intrinsic tissue repair, whether it's really hyaline cartilage that can still be discussed, but at least we see structural changes and we can learn from that. So instead of using a trial and error approach, trying one of the mechanisms to inhibit it, for instance, by using an inhibitor or maybe a combination, we feel that we need to study those patients in more detail and learn from them and see whether we can translate that knowledge to the more a general OA patient or a certain subgroup of OA patient, and what we call an inside-out approach. Early this year, we published a review on that and how we think this is of value to do that. So this is what we want to continue for the coming years and see whether, this is useful to do, of course. One of the things that we did was making use of the approach cohort, which is very shortly showed here. Mylene will tell you in more detail in a moment. It's a cohort of about 300 people, but 150 of them are from our hospital, and they were screened and seen at baseline, 6 months, 12 months, and 24 months. And at those time points, a lot of data is collected general physical examination, joint examination, radiography, CTs, MRIs, hand scan, emotion analysis, all kinds of tests. Mylene will provide you more detail on that. But what we were interested in was getting synovial fluid. We were a bit unlucky with the pandemic. Well, the whole world was, of course, unlucky with the pandemic. Useless to say, I would say, but we were a bit unlucky. But due to the pandemic, we were only able to obtain the synovial fluid from those patients at the end point, 24 months. But nonetheless, that's still interested to see what's going on in the synovial fluid and see how that relates to all the parameters that have been collected in the cohort and whether we can see whether there are differences. We were not able to collect from all those 150 patients. Not all patients approved to the ethical procedure, but and not every patient that was giving approval but could be successfully be synovial fluid obtained. But we have a data collection of 40 patients, so that's still quite a large number. And we're now working together with Nordic Biosciences to analyze the synovial fluid for specific markers. Markers for pain, markers for fibrotic changes, but also the more common cartilage and synovial markers will be studied. And these will be related, of course, to all the data that we already collected from those patients. So again, a combination of making use of a nice cohort and the things that we can do. And a new step that we're going to take is that we, besides that, the focus that we did on the OA, we want to start with more translational fundamental research on systemic sclerosis, where we are currently exploring what we really want to do. We have a trial where we treat those patients with stem cells, and we want to know what the exact role of those stem cells is, so that we know from the clinical effects that there might be an effect, but how that really works and in what extent it's really a stem cell effect or a reset of the immune system. We need to study that in more detail. That's something where we want to start. We want to look more in the role of imaging. Can we refine that or add other imaging to that? We want to start, of course, with ultrasound, which is much used in our clinics, and see whether we can optimize that. And we are starting to look at the role and understanding of hand impairment, which is a really big problem with those patients, but there's not much research done for this type of disease. So we want to understand whether there is a specific mechanism going on and whether we can see that in a more early phase in those patients where we can do something about it or try to do something about it. So this is really newly development where we want to start working on. So this is a different type of field. Most of all, and I think that's really important, because I'm representing this work now and telling this work, but it's teamwork. And all the different students, PhD students, master students, technicians, research nurses, everyone is needed to really make a step forward. And of course, also the people who are funding our research is very important. And with that, I want to give you a short overview of our OA research line and what our future will be. And yeah, if you see opportunities to work together, please reach out. We're always open to that. And yeah, and I hope you had a good idea of what we can do in Utrecht. And I'm not, well, if there are any questions, I'm more than happy to answer them.
I have a quick question about the joint distraction method. This is Richard Loser. I appreciate your overview. That was really great to see everything that your group is doing. At least in some preclinical models, it seems like if there's any repair of cartilage, it's cells from the synovium that actually repair the tissue. And I'm wondering if in the studies that you've been doing with joint distraction, if you've been able to see, whether or not any of the tissue that's growing is related to synovial cells coming in and actually, serving to repair the tissue, or if you think it's truly, some type of cell within the cartilage itself.
Yeah, thank you for your question. That's a very Good question, and together with the group of Professor Dennis McGonigal from Leeds in the UK, we started to study that, and because indeed one of the theories that we have is that indeed that the stem cells or progenitor cells, I call them stem cells, but there might be progenitor cells, MSCs, from the synovial tissue might be the cells that add or are fully responsible for the repair that we see. We had plans for that, but we never got the real funding for that to study it properly. But that's the way that we also think and believe that the synovial tissue is really important. On the other hand, we know that those progenitor cells are in all the different structures present, even in cartilage, so we cannot rule out that those cells are also involved. But that type of studies are really interesting to do, but we haven't been able, and we aren't able in the dog model to study that in such a detail. Another important compartment, which is important, I think, for the repair tissue that we see, is also the bone compartment. There we see quite significant changes occurring upon joint extraction. So I don't believe it's one tissue, but I'm certainly agree with you that the synovial tissue and the cells involved there might be one of the leading cells, I would say, coming from top, if you can imagine that, and landing on the damaged places in the joint.
Thank you.
When there are no other questions, I'll stop sharing my screen and I go over to the presentation of Mylene. There we are. If I'm correct, you will see the approach slide now.
Yes.
Yep.
Thank you.
Okay. Yeah, so well, as the slide said and has been introduced already, I'm going to show you a bit about the approach cohort. I'm going to introduce it to you, show you the data that we've collected, and present the highlights that we've seen so far.
Yeah.
Yes. Well, approach is actually short for Applied Public-Private Research Enabling Osteoarthritis Clinical Headway, but I don't think anybody knows that by heart. It's a 2-year multi-center European exploratory study where patients were included from 5 different medical centers throughout Europe. A little bit of background on why it was initiated. As you probably all know, OA is typically a slow and heterogeneous disease, which complicates a treatment showing efficacy in clinical trial using traditional outcome measures that have been used so far. And new biomarkers or markers to predict disease course or to serve as sensitive outcome parameters could help overcome this problem and potentially help distinguish OA phenotypes. There have, of course, been previous cohort studies that have definitely increased knowledge on OA, but still no clear phenotypes or predictive biomarkers have been found. So that was one of the goals of approach. These were actually the 4 objectives. I'm not going to read them completely, but as you can see, it was about validating and refining prediction model to predict patient that would show sustained pain or pain increase or a decrease in joint space width over time, and to develop and validate new sensitive markers for OA progression, discover and predict novel phenotypes, and describe these phenotypes using traditional but also novel biomarkers. And what's also new about this cohort is that patients were recruited from previous observational cohorts using machine learning models. So these models were trained using patient data from a Czech cohort, and they were trained to predict which patients had an increased likelihood of showing structural and or pain progression over 2 years. And only those patients with the highest likelihood were then included in the approach cohort. So just an overview of how the recruitment worked. These are the 5 cohorts that the patients were included from. And on these cohorts, the first machine learning model was let loose on the patients that were willing to participate and didn't have any exclusion criteria beforehand. So these were all models that were cohort specific. From these, 317 patients were selected that were likely to show, or a bit more likely to show progression over follow-up periods. These were added to this were newly selected patients from outpatient clinics to get to a total number of 433 patients that were screened. So they came to the hospital for a screening visit. At this screening visit, we checked in an exclusion criteria, which are written here on the slide. We also selected their index knee, which was based on ACR criteria. So if one knee met the ACR criteria and the other did not, then that knee was selected as the index knee. If they both met the criteria, we asked the patient which knee was bothering them more, and then that one was selected. And if also there was no difference, then the right knee was selected as the index knee. And in the screening visit, we collected data that were turned out to be key predictors from the first machine learning model. So these were the reduced KOOS, BMI, NRS pain in the index knee, age, gender, and KIDA parameters of the index knee. KIDA is the measurement software that we use for knee radiographs. So this parameters like the joint space width and the subchondral bone density that were measured from the weight-bearing knee radiograph. So all of this data was collected to the screening and used for the second model, which was uniform for all cohorts, second machine learning model. And with this model, the final inclusion included patients were determined, which is 297 patients. So these are the patients that had the highest likelihood of showing clinical and or structural progression over the 2 years of follow-up that the approach would have. More specifically, the machine learning model gave a P-score and an S-score for all of the participants, which were both a score ranging from 0 to 1 and reflecting the likelihood of the patient showing pain or structural progression over 2 years. Structural progression was defined as a reduction in joint space width of at least 0.3 millimeters per year. So if a patient showed that, then he would be a structural progressor. And pain progression could be shown either as sustained significant pain or as pain increase. More specifically, it could be significant pain increase with at least 5 points in the KOOS pain scale per year and at least 40 from 0 to 100 at 2 years, or fast pain increase showing at least 10 per year, KOOS points per year, and at least a score of 35 at 2 years, or the third possibility was stable significant pain, where patients had at least 40 on a scale from 1 to 100 in KOOS pain at baseline and at 2 years follow-up. These are the screening characteristics of the patients that were included and were excluded. So again, the included patients were the ones that were predicted to show higher likelihood of pain or structural progression than the excluded patients. As you can see, the baseline characteristics are actually significantly different for most characteristics. So in general, included patients were more female patients. They had a higher BMI, they had more pain, they had the higher minimum joint space width, and unfortunately we do not have the Kelvin-Lorentz rate of the excluded patients, so we cannot compare that. But it is important to see here that around half of the included patients actually had grade 0 or grade 1 Kelvin-Lorentz rate of the knee, so around half of them didn't actually have radiographic OA at baseline. Well, what were the parameters that we collected? That was a lot, as Simon already said. Clinical parameters are listed here. So there's medical history, general physical examination, and joint examination of the hand, knee, and hip. Patients came to the hospital at several time points. After screening, they came again for a baseline visit, which was relatively soon after the screening visit. And then they came back at 6 months, 12 months, and 24 months of follow-up. And at all of these time points, we collected at least clinical information. We also have a lot of imaging that was done. We have radiographs of the index knee and the contralateral knee in the hands. As you can see, we have not just these radiographs available, but also a lot of scoring. So I have the KIDA scoring, which is, as I said, osteophytes, so-called bone density and joint space width. We have Keltner-Lawrence grading, Altman scoring, and bone fractal signature of the index knee and the contralateral knee. Then we have Keltner-Lawrence grading of the hands. We also have CT scans of the index knee at baseline and at 24 months follow-up, from which the shape analysis has been performed and subchondral bone analysis has been performed. And we have whole body low dose CTs, where OX scoring has performed of all the joints at baseline and 24 months follow-up. Then we have MRI scans of the index knee, quantitative scans and qualitative, semi-quantitative scans at all time points, from which cartilage thickness and the bone area were measured, but also the semi-quantitative MOX scoring. And we have T2 mapping at baseline at 6 months follow-up for as a qualitative cartilage MRI scan. And we have the hand scan at baseline and 24 months follow-up, which is a scan that measures inflammation in the joints in the hands. We also have functional parameters. We have motion analysis with the GateSmart system and 2 performance-based tests at baseline 6 months and 24 months of follow-up. We have a lot of questionnaires that these patients filled out, most of them for the knee, but also for other joints, and they are almost taken at almost all the time points. They were specific for mostly for pain, as you can see. And lastly, we also have biomarkers. We have serum, plasma, DNA, RNA, and urine at baseline and 24 months, and some of them also at 6 and 12 months. Well, we already have some of the first publications of the 2-year results. As you can see, they're mostly by Evie van Helvoort, whose PhD thesis she defended last month, and it was mainly about approach. I'm not going to focus on all of these, but these 3 I'm going to talk a little bit about. The cohort profile is a publication showing everything more or less what I presented before. And I want to show you a bit about neuropathic pain, which Simon mentioned before, and the 2-year actual and predicted progression in this cohort. So the predicted progression, as I said, was 0.3 millimeters minimum joint width loss per year. So that's 0.6 millimeters over 2 years. And as you can see here, around, depending on if it's a 2-year change or a regression over 2 years, then the percentage of progressors was between 18 and 24%, so not incredibly high. Pain progression, which, as I mentioned before, could be either a pain increase or stable significant pain. We see that the progressors were a little bit higher. So here we see that around 27% of all patients were a progressor. So they did fit the definition of pain progression. And around 2/3 of those patients that showed progression, they showed stable significant pain. Then if we look at how well the P and the S scores could actually predict progression, the S score did not very well predict whether or not the patient would be a progressor. The area on the curve is around 0.6, as you can see. If we look at the pain, we see that the P score could predict progression a bit better, because the area on the curve is around 0.82. And if we then look at the 2 different definitions of pain, so either pain increase or stable significant pain, we actually see that the predictive value of the P score is mostly good for the stable significant pain, with the area under the curve around a bit more than 0.8, and it could not very well predict pain increase. We also look at the association of the S score with other types of structural progression, so not just the minimum joint space width predefined definition that I said before, but also we look at progression of mean joint space width, quantitative cartilage thickness, MOX, cartilage damage scoring, subchondral bone density on radiographs, and bone marrow lesion MOX scoring, and osteophyte size on radiographs and osteophyte MOX scoring. Progression on all of the continuous parameters was defined as a change of at least the smallest detectable change, and for the MOX it was defined as at least 1 full score increase over 2 years. And the right column shown now, you can see how many patients, or the percentage of patients that was actually a progressor. As you can see, this is mostly high, the highest for quantitative cartilage thickness, subchondral bone density, and osteophyte size. All around 1/3 of patients showed progression over 2 years in these parameters. If we then look at how well the S-score could predict this progression, in most cases, the S-score could not significantly predict whether or not the patient was going to be a progressor over 2 years, except for the minimum joint space width. But an important note there is that the baseline minimum joint space width was used for the calculation of the S-score. So that's like cheating a little bit. And if we correct for the minimum joint space width in the prediction model, then the S-score can no longer significantly predict whether or not the patient is going to be a progressor minimum joint space width. Then a little bit about neuropathic pain. As Simon already said, we used the pain detect questionnaire in the cohort to identify patients with a high likelihood of a neuropathic pain component. And approach, it turned out to be 24 patients that had a high likelihood of neuropathic pain component. And they were matched with 48 patients who did not have this from the approach cohort. They were matched based on Coues pain and SF36. And it turned out that neuropathic pain patients had similar pain in their index knee, because that's what they were matched on, but they had significantly less damage in the index knee, both for Kelvin-Lawrence space, for joint space width, for osteophytes, and for subchondral bone density. And at the same time, neuropathic pain patients had more pain in all the other joints, but similar damage based on the whole body CT OACT scoring. So from this, we concluded that these patients may represent a specific phenotype where joint damage is not the main cause of pain and disability, and these patients will then likely not benefit from, for example, D-mode therapy. So the conclusions of the whole cohort so far, thanks to the achievements of all the participating centers, we had 70% dropouts and less than 5% missing data in all the performed visits, despite the COVID restrictions, which were visible especially at 2 years follow-up. And all of this has led to a very unique and high quality data and imaging set. Around 1 in 4 patients in the data set show pain progression, especially stable significant pain, and the machine learning P-score calculated machine learning algorithm could predict pain progression rather well. And around 1 in 5 patients showed structural progression, and S-scores as calculated with the machine learning models were not generally associated with whether or not the patient was going to be a progressor. We've seen that patients with neuropathic pain component may represent one clinically relevant phenotype, and I think a very important inclusion or conclusion is that there's many data left to be analyzed in the cohorts, and further analyses in this approach cohort will provide more insight in OA prediction, biomarkers, and phenotypes. I think that was it. Yeah. So, do you have any questions?
Great, great. Thank you so much. Is the approach data currently or in the future to be publicly available, or is there a data use agreement, or how does one access the data?
It is available at the moment in collaboration with one of the partners. So it's not fully publicly available. It's available to all of the partners that were involved. And if you want to do something with this research, you can collaborate with one of the partners, and then data will be available to you. I think in the future it will be publicly available, but that will be, I don't know when.
That will take, so since the primary analysis and all the partners have done their analysis and the spin-off that they aimed at, so probably 1 or 2 years before it's fully publicly available. But like Mylene said, once you connect to one of the PIs in the project, then you already can have access to the data that you want. If you want to do that, you need to apply with a form and explain what you want to use and why you want to have to use it, and then there will be a committee looking at whether it's relevant, etc., etc. But
and who to best collaborate with.
And who best to collaborate with. But if you connect it to one of the PIs involved, it's already logical that you want to do something logical, I would say. So in principle, it's relatively easy. Let's put it that way.
Richard, did you? Yeah, go ahead.
Yeah, I had a couple of questions. The approach study is going to be really interesting to see what you find when you start to look at phenotypes using all the biomarker data and everything else. I'm wondering if there's any plans to extend beyond 2 years. As you know, in the course of OA, 2 years is still relatively short. The osteoarthritis, initiative was able to go out to 10 years. And I think, as they got more data from longer time points, things became more significant. So I'm kind of wondering if the funding and everything is going to limit you to 2, or there's a chance that you're going to be able to take it out longer than that.
It was limited to 2 on purpose, to try to find results that would be clinically relevant. And also because we tried to include only fast progressors, so you would think over 2 years you'll already see some significant changes. And as far as I know, there is not any funding for longer follow-up. So 2 years is, at least for now, really the end.
Yeah, for this cohort, there's no funding available. Of course, we have funding to keep the database and stuff up and running for a prolonged period. But yeah, we need to apply for additional funding and see whether we can call those patients back in a certain moment in time. But then there need to be additional funding. And yeah, unfortunately, that's always a bit. The long term is always a bit of a problem, right. Also for the funding agencies. Yeah. But I agree that there's more to learn in time, because there can be really a change or a pattern of waiving within time of patients regarding pain, for instance, or developing structural damage on a later stage, maybe. Yeah,
that was actually my other question. Is OA really does seem to be more of a phasic disease, rather than linear. And so I'm wondering, in terms of looking at progression and pain, if you're able to kind of tease that out with the data that you have, if you're able to see, phases of progression versus just, progression over the 2 years, and sort of see what associates with a phase where there's more rapid progression and then things slow again.
And we do have the data that was collected before approach, of course.
For some of the patients, yeah.
Most of them are from previous cohorts.
Yeah.
But then we don't have all of the data that we have in approach. You have radiographs, for example, but you won't have all the biomarkers. And
so there's limited. The synchronization of the different type of data is limited from the original cohorts, and so that's also something that we learn. But if you really want to try to compare in time different types of studies, you really have to have a good look in what you are collecting. And of course, this is not a new phenomenon, but we still keep forgetting that when we start studies. Yeah, that's a bit my feeling. And that was also the case here. It was thought that we could really easy combine those original cohorts, and then there were 2 different to start with. You have to start a new cohort really and start newly prospectively collecting data. So there might be some limited options to look back and see whether there's that phasing in those type of patients. At least I think, because what we have studied and what Mylene now presented was one of the phenotypes which seems to be on the pain side, regarding more neuropathic related patients. But another phenotype has been done by Jaume from Newcastle, where he could find some differences in biomarkers. So that needs further analysis. So maybe also there, because that's a more dynamic markers, of course, there you can maybe see more in phasing of those patients, but that needs further research.
Yeah. Okay. Yeah. Thanks.
Also, I don't want to interrupt the question process. I'm just going to launch the poll to make sure everyone has a second to answer, but please keep doing Q&A. I just wanted to get that out there.
Yeah. Thanks, Kate. Any other questions? I have a couple of more specific technical ones that I'll shoot to Mylene a little bit later. But thank you very much. I think this was super interesting, and there's a lot of overlap with our group. So don't be surprised if you hear from one or more of us in the near future. Okay.
Yeah, you're more than welcome. If we see opportunities to collaborate, we're open to that. And yeah, always looking forward.
Same here.
And thank you for your attention.
Yeah.
Thank you.
Thanks.
Okay. Bye-bye then.
Bye.
Have a nice day.
Thank you. You too.